Okay, well, welcome everybody to this webinar on real-world data and the COVID-19 pandemic. I'm Gillian Schmidler, and I'll introduce myself a little bit more in a minute, but I wanted to welcome everyone and let you know that this is co-hosted by the National Health Council and the Duke-Margolis Center for Health Policy, and this is part of our joint educational series on an introduction to real-world data and real-world evidence and a virtual training series for the patient community. Next slide. So before we get started, I want to go over a few housekeeping items. First, the webinar is going to be recorded and it's going to be archived on the NHC website. And you can find it at the same location as where you registered. All the participants are automatically muted when they entered, and we're going to have time at the end for questions and answers. So please submit your questions to the QA section at the bottom of the screen. Next slide. So this webinar is part of a PCORI-funded training series for the patient community on real-world data and real-world evidence. And we'd like to extend thanks to the advisory board members that are listed here. So thank you. And next slide. Here's a list of the previous seminars in the series. And then the next one in the series is on case examples of patient-centered real-world evidence, which is on March 12th. And so if you're interested, please head over to the NHC website to register or to view any of our previous webinars. Next slide. So today we have two speakers. So myself, Gillian Schmidler, and I'm just going to talk for a few minutes and really save most of our discussion, talking time and discussion time for Blythe. I am a professor of population health sciences and medicine at Duke University, and also the deputy director of the Duke-Margolis Center for Health Policy. My research focuses on evidence-based decision models, using them to evaluate comparative effectiveness of different prevention, treatment, and management strategies, and translation of those models into formats and tools that patients and providers and policymakers can use in their decision-making processes. I'm past president of the Society for Medical Decision Making, and I also co-chaired the second panel on cost effectiveness in health and medicine, and also currently am co-chairing the Society for Medical Decision Making's COVID modeling subcommittee. And then after a few introductory remarks from myself, we'll have Blythe Adamson. She's a health economist and epidemiologist and currently serves as the director of quantitative sciences at Flatiron Health, which is a health tech startup company in New York City. And she's also an affiliate assistant professor at University of Washington. Dr. Adamson helped scale data curation and evidence generation from 2.2 million patients with cancer to identify valuable cancer treatments and effective healthcare policy looking to improve patient lives. But most relevant to this talk is in the spring of 2020, Dr. Adamson served on the White House COVID-19 task force on healthcare resilience. And that work, which we'll hear about today, really builds on her prior research experience at the HIV vaccine trials network at University of Washington when she was there, and then also within ISPOR and other organizations. So I think you guys are really going to enjoy hearing from Blythe and her experience, both in terms of where the work that she's been doing and then also where things need to go now. Okay, next slide. So I just wanted to say a few things related to the intersection of real world data and the COVID-19 pandemic. So next slide. Back last March, when the pandemic really started within the US, the Duke-Margolis Center, we came up with a categorization of the COVID-19 response, some of the different areas where we needed to be making decisions and needing to be figuring out what is the evidence we have, how can we actually inform decision making. So we categorize these into public health interventions. So example, what are the different mitigation strategies for physical distancing, for contact tracing, how to really be looking at those types of strategies. Then there's questions or response related to diagnosing, testing, and evaluation. How do we, implement those? Questions related to hospital operations, what we should be doing within our healthcare systems. Questions related to treatment and vaccination, and then also ones that focused on the individual and population level well-being. But now, even within these different categories, the questions are going to be different depending on the different perspectives you're coming from. So one of the kind of sets of work that we did early on was really trying to working with different policymakers, see what their uncertainties are, what their questions are, and how could we actually help inform those decisions. So next slide. So in the next few slides, I'm just going to show you some example questions that we heard from different types of decision makers. So here are some examples for policymakers. So for example, in the diagnosing and testing and evaluation, who should be prioritized for testing to aid in reopening and management of the pandemic? Or in the individual and population level well-being, what role does affordable housing play in mitigating infection risk? So these are things that population policymakers might be thinking about. Next slide. For clinical decision makers, there are other questions. So here, for example, in the public health interventions, what are the short and long-term impacts of non-COVID illnesses during the COVID mitigation process? Or for the treatment and vaccination, what are the optimal approaches to implementing shared decision-making related to ventilation or palliative care in older patients? So different things that a clinical decision maker might be thinking about. Next slide. And in terms of health system administrators, again, the questions differ. An example here on hospital operations might be, what can we be doing to minimize the impact of flu season on already strained hospital resources? Or the individual population is, how can we look at the benefits of nursing homes and long-term care during this time, and how that might change with from Medicare, investment from Medicare and Medicaid. And then finally, next slide, all of us are members of the public and patients in some form. And then again, here, there's questions that individuals are having, for example, what are the mitigation strategies that need to be in place before we could feel comfortable sending my child back to school? Related to treatment vaccination, is it safe for me to get vaccinated? Once vaccinated, what can change in my daily activities? For diagnosis and testing, should I get a COVID test before traveling by airplane to visit my family? Hospital operations, should I go in to see my primary care doctor for an annual exam, or should I cancel? And then the individual and population level well-being, how can I feel connected to others in my community while also being safe during the time of COVID? So there was lots and lots of questions, and these questions have actually changed over the last year as we've gotten more information. And next slide. So really the question then is, how can we use real world data to help us answer these COVID-19 questions? And this is, I think, a wonderful opportunity for us to really see the power of real world data. It's, the underlying disease course, was uncertain, continues to have some uncertainty involved with it. Our evidence that we have available is changing over time. Every day we're learning more about the different strategies and their effectiveness and their limitations. The evidence is coming in different forms. It's of varying levels of quality, and we have to know how to assess that. And it also really represents diverse populations and strategies, and it's incredibly complex. So the evidence is being gathered in less than ideal situations with lots of different strategies happening at the same time, and needing to really figure out how they all contribute to the findings we're seeing. Our strategies for preventing and treating COVID are changing over time. And so any of the data that we're looking at, we really have to be clear on what that's representing. And then we need answers now. So this isn't something that we can do, a 5-year trial to see what the best solutions are. We need to be knowing how to be treating patients, how to be preventing disease, and how to be moving forward. And we want our decision making to be continuously updated with the latest evidence. So we're not just making a decision now and moving forward, we're making a decision and continually wanting to update it to reflect the best knowledge. And then the other thing is that we want to be making decisions that are going to optimally prepare us for not only the next kind of twist and turn within this COVID pandemic, but that are also going to prepare us for future pandemics. And so really trying to understand what's the role of the real world data and evidence, not only for COVID-19, but for whatever comes next. And so I'm now going to turn it over to Blythe to talk through some of the work that she has done as part of the pandemic. But then we'll at the end open up for a broader discussion with the group, related to real world evidence and data and the response to the COVID pandemic. So, Blythe.
Well, thank you for having me. It's just an honor to be invited by you and to be with all of these partners and guests of NHC and Duke-Margolis. I really appreciate the framework that you laid out of all of the different perspectives and applications and questions that we have during the pandemic that we can use real world data to solve. And often it's the finding the question and matching it to the right type of real world data to help reduce the uncertainty in those decisions where we really see things working well. And so I'm hoping to bring this to life for you with a few case studies that I've picked that fall into some of the buckets that Dr. Schmidler laid out for us. So next slide. And this is really building on the sessions that you've already had in this series. So you've built now a foundation and an understanding of what is real world data, where do we find it? How is it curated? What do we use it for? And can we even trust it? And in some of the past seminars in this series, one of the biggest applications that was discussed has been using real world data to understand the effectiveness of treatments in the real world. Is drug A better than drug B? And in clinical trials, we can understand that through randomized controlled trials, and then also try to observe that in the real world. And what I'd like to highlight now with the pandemic is the different opportunity that we have. It's pretty difficult to randomize public health policy. So while we might be able to design a trial of drug A versus drug B, we can't really randomize states to lockdown or not lockdown for us to be able to quickly solve, do lockdowns work? Governors would never accept that. But real world data is going to allow us to think of interventions and test the effectiveness of interventions that really can't be randomized at all. So next slide, why am I here? She mentioned before that I was called to Washington, D.C. In mid-March, and really based on my expertise doing in pandemic prediction modeling, joint with training in economics to understand and evaluate some of the policies and decisions that they were trying to make. And it was an intense time when a lot of real world data was trying to be assembled to give situational awareness and understand where this is going. And so I want to show you just a few examples of the types of questions that we were asking and answering with real world data. Next slide. The first question that I faced when I landed in Washington, D.C., took a cab straight to FEMA and started listening. And what I heard was that people were freaking out about Italy at the time. In mid-March, Italy was rationing ventilators. And there were so many severe cases of COVID in Italian hospitals at the time that if you were over 65 and a severe case, you were not allowed access to a vent because of this shortage. And leadership in DC were all of a sudden panicked in realizing the threat, both to our health and our national security. But the question was, what we wanted to achieve was, we don't want anyone to not have what they need, have the hospital resources that are needed to care for people well when they are sick. But when is the peak going to happen in the United States, and how high will it be? How can we ramp up the resources that are needed? And unlike a lot of the academic prediction modeling I had done in the past, where you're trying to come up with a precise estimate and a 95% uncertainty interval, the questions were much more basic. Is it 4,000 vents or do we need 400,000 vents? Because it really changes the action that we need to take. If it's just cutting in line to buy more from a manufacturer, or do we need to ramp up the manufacturing, domestic manufacturing in the US, or do we need to transform some of these auto plants to start making new hospital grade vents? And on the next slide, you'll see that at that point in time, there wasn't that much information. Where at that point we were sitting right where that red circle is, where the trajectory was just going straight up. And it was really, really challenging for us to account to be in a situation that's often true in public policy, where the data you wish you had to answer that just doesn't exist. What's the exact number of ventilators in the United States? No one knew at the time. And this is where we're often led to, okay, what's the next best real world data source that we can use to inform this? Is it COVID deaths that are happening over the rate that they're happening and increasing over time to make these predictions? And one of the most informative ones really was the hospital ICU capacity. Learning that most hospitals have about 1 ventilator per ICU bed. And, learning that and seeing New York at the time really creep up and exceed their ICU capacity and expand the number of ICU beds that they had. So on the next slide, you'll see ventilators are just one example of many difficult questions that were being asked at the time. With the national stockpile full of gowns and masks and gloves and shortages felt around the country, what's an equitable way to distribute this PPE to the rest of the country? Are lockdowns really slowing the spread because people are losing work, they're losing their livelihoods, you're falling into poverty, going hungry? How do we weigh these trade-offs? And is it worth it? Are we achieving the gains of slowing the spread from shutting everything down together? And when is it safe for us to reopen K-12 schools? It's such a controversial topic to discuss when children are so precious and seemingly vulnerable to us. Yet at that point in time in March, there wasn't really evidence that that this virus was disproportionately affecting or hurting children at the time. And is that true, or is it just what we observe because maybe we haven't been testing kids? So next, we see that the real world data types don't always exactly match the questions that we want to answer. We can look at case counts by location, the lab testing results that come from these huge reference labs. But one of the interesting things that we saw as real world data use just exploded during the pandemic to cope and make good decisions was the use of some new forms of data. So I think that it was much less common for people to be using smartphone tracking data before the pandemic. And this is a tool that I'll go into with an example in a little bit. And we also saw some novel ways to use electronic medical records data to be able to answer some of these questions. And on the next slide, I would say the full circle application of real world data during the pandemic is the clear communication to policymakers to actually inform with evidence the design of good policy. So in this photo, it was a collision of many different projects and work that I had done with Dr. Fauci's team on vaccine development, Dr. Birx's team on lockdown policies, and the governor of Louisiana. And it was so rewarding to meet with him when we were one of the first to predict or observe the surge that was happening in New Orleans right after Mardi Gras. And it affirmed to us the dangers of bars and restaurants and indoor large gatherings, and the necessity to be able to respond, have a fast public health response. But even with the former president and with an economist, Kevin Hassett, sitting beside me, it's the I think my biggest lesson in trying to answer these difficult decisions with real world data, the final necessary step is clear communication in partnership with stakeholders who have the ability to take that information and make those important decisions. On the next slide is what I was referring to before of the exciting ways that smartphone data was used during the pandemic. And I know that in one of your prior sessions, you have talked about and explored, how is patient privacy handled with this type of, very seemingly identifiable data. And we saw two leaders really emerge in this space during the pandemic. One of them was SafeGraph Data, and another was Google. And both of them took the same approach of aggregation of people's smartphone data and tracking data to be able to protect the identities of individual people. And we saw CDC use this type of data. We saw major sports leagues and even local governments be able to not just understand where are people located, but how are they moving? And the most meaningful ways that I saw smartphone data analyzed early in the pandemic was in the evaluation of the effectiveness of different policies that were implemented across the United States. So in some counties and states, we saw, very light restrictions. Maybe they closed gyms and restaurants, but most workplaces were open, where other states then closed, locked everything down. And it allowed us to then observe, how is movement changing? How is the average amount of time you spend at home in one day increasing in response to this type of policy change? And then, is that really on the pathway to that explains to us the resulting slowing of spread? And on the next slide, another interesting and meaningful way that we saw EHR data used in the pandemic was through electronic medical records. One of the first groundbreaking ones that was meaningful to me came from the UK, actually, where it took half of the UK population, their EHR data just from their primary care provider, and linked it to their UK's COVID death registry. And what it revealed to us were similar racial disparities that we saw in the United States, but it also showed us nuances of groups that were especially at risk of dying from COVID in the general population. One of those groups were people with cancer. And it revealed that not everyone who is a cancer survivor was at increased risk of death from COVID, but people who were particularly at elevated risk were those who had been diagnosed in the last year and were on treatment. And in this graph here, which was published in the Cancer Letter using Flatiron data, it shows us the dramatic changes in the types of community oncology clinic visits that cancer patients were going to during the pandemic. So we see that the chemo visits are going down, non-chemo visits dramatically down, and there's a pretty meaningful increase in telemedicine. And this helps researchers be able to tease apart, what is it that makes cancer patients more at risk of dying from COVID? Is it the exposure? Is it that going in for chemo and sitting for an hour, getting an infusion in a large room with other people or the transportation to get there makes someone more exposed to COVID? Or is it that the drugs themselves are making that person more vulnerable, more immune compromised, and susceptible to dying from COVID if they become infected? And next slide, you'll see that there are so many different areas of our economy and of opening and being able to bring people back to work safely. And I think one of a really interesting case study is how Major League Sports handled this, where you saw these rigorous testing programs with daily or twice daily PCR testing done by the NBA to create this safe bubble environment, or the NFL, who used tracking devices to be able to alert the administrative staff if players were in proximity to other players for too long of a time, sort of breaking the social distancing expectations and allowing them to do rapid digital contact tracing. So I think many of the lessons learned and what the real world data from the intense sequence of frequent tests also gave us clues at the biological level of what the viral dynamics even look like for COVID. You know, we're so used to seeing, we've seen so many curves of what an HIV viral load trajectory looks like. But until we had data from the NBA and from these leagues where they've tested people every single day, we hadn't before yet known what does that look like with SARS-CoV-2 viral load trajectory, and what does that mean for the duration that someone is infectious. Next slide. One of the most meaningful things to me after working in, spending many years working in HIV vaccine development and knowing how hard it is to develop something that actually works in the real world. Just this week, we saw a New England Journal of Medicine paper published with the EHR data of an astounding share of the population in Israel, where they then took patients that had been vaccinated for COVID and matched them to patients that had not yet been vaccinated, and showed the vaccine effectiveness in the real world was almost identical to what was observed in the trial, which gives us so much more confidence and affirmation that we can have hope that there are things that are available that are working, but it also will give us many lessons we can apply later about how we can design good real world data studies in the future. And the last case study I'll mention, next slide, is about K through 12 schools. So I mentioned before, you know, we think that kids are probably less susceptible to, you know, becoming infected, less likely to have really bad outcomes, you know, probably less likely they pass it on to other people. Yet in some of my work with designing testing programs for universities and K through 12 schools, I remember the first university that I helped with, when we tested the whole population routinely, 99% of the positive cases had no symptoms at all. And it's terrifying to think how the spread across campus can be invisible if we're not paying attention. We're not understanding how the virus behaves differently in different types of people. And so it affirms to us that, you know, one of the key components of safely reopening K through 12 schools is probably going to be through testing programs that, you know, are not, they're necessary, they're not sufficient, you know, obviously combined with masks and all of these you know, public health hygiene prevention measures that we know are good to institute. But the real world data has allowed us to understand, you know, okay, there's lots of different kinds of COVID tests with different prices, different time to results. And it's been wonderful to see how quickly real world data has been used to help schools identify, you know, what's the right type of test or frequency that we should be testing these students, or pooled testing versus individual. And I think that it's so important that CDC has had a strong role in guiding these schools about how to open when, you know, having schools open, especially K through 5 schools, is so important for us to be able to have a strong economic recovery. So next slide, in conclusion, I think that the pandemic really has forced an explosion of RWE, our familiarity with it, our identification of new types and ways to use it. It's affected our trustworthiness of real world data and our skills in being able to evaluate the quality of it, all things that you've talked about in your prior sessions. And it's really been used to help quickly generate intelligence for, when you have to make a decision right now and it has a huge amount of uncertainty. How can we use real world data to help reduce that uncertainty? And it's allowed us to be able to quickly evaluate public health policies that we know we can't design a randomized experiment for, but we can see masks work, that closing restaurants and bars work. Those are things that we learned not because of a prospective randomized clinical trial, but because real world data, collected in real time, curated quickly, and analyzed with communities of open scientists working together made that possible to achieve. And I think going forward, surveillance will continue to be one of the foundations that inform public health policy and help us track and make sure that they continue to work, so that as new risks, such as a variant from South Africa that we may be less protected from, that the policies that we have in place are working to continue to protect the population. So next, I just wanted to thank PCORI for funding this really important series of work. And next, just thank Dr. Fauci and the White House COVID Task Force, as well as the thousands of hardworking civil servants that are behind the scenes, the unsung heroes at FEMA, HHS, the Pentagon, who are working together to push this forward. And lastly, next, my contact information. It's just a pleasure to be with you today. I'm looking forward to the questions that you have, but here's my information if any of you would like to follow up afterwards. So thanks very much.
Great, thank you. So we now have some time for questions and answers, and I'm going to start off with a few that I've seen come in, and we can go from there. But certainly, if folks have additional questions, you can put them in the Q&A, and we'll or in the chat. So one of the questions, Blythe, was about the quality of real-world data and how we're evaluating that during the COVID response, and so that we can increase the trust within the real-world evidence results. What your thoughts are there?
Oh, I'm so glad that this question was asked, because it gets at the heart of some of the things that real-world data scientists have been trying to get people's attention about for a while. The ones that come to the forefront of my mind are missingness and representativeness of data. So, when I think about representativeness at the beginning of the pandemic, when we were thinking about, how do we distribute the stockpile of PPE? Okay, well, there's a bunch of cases in this state. Is it true that there's more cases in this state, or is it that the people who live in those areas, those wealthy neighborhoods, had access to those sites, and that the neighborhoods that maybe have lower socioeconomic status and a higher burden of disease, if they don't have access, the same access and use of the tests that are available, then what good should we have trust in the quality of the evidence that's produced from this testing data if it's not representative under the hood? And then missingness, oftentimes similar to representativeness, the elements of these affected patients' lives that we don't get to see or don't get to understand are often so related to confounders or our ability to trust the evidence. So I think that it's an ongoing challenge that we have to continue to work on together as a scientific community.
Yeah, that's great. And I guess an additional question is about the role of consent in using real world data at the population level. I mean, especially when you were talking about the cell phone data or other things like that, what do you feel is the role of consent?
Right. With that type of smartphone tracking data, which is a product of SafeGraph, it's a collection, my understanding of it, assembled through many apps where users in downloading the app and accepting terms um, agree and provide consent for the data collected by that app to be used. And so I think it does reveal that oftentimes we're consenting to things without maybe even reading the fine print or fully understanding it. Yet that's why it's so important that, that as we think of HIPAA and privacy, that we're continuing to ensure that IRB reviews are conducted whenever when it's necessary, and that new software tools and techniques like the aggregation of data allows the opportunity to learn from smartphone data without having any risk of interacting with anything that's at the individual person level. So I think it's one of the advances that we're getting out of the pandemic is learning how to have the depth without violating privacy.
And similar to that, so one of the questions was about the COVID vaccination data and whether is that being tracked kind of globally, and is that actually available for researchers or industry for analysis, and if so, kind of how that is accessed?
Right. One of the things that the pandemic has revealed in the United States is both our fragmented healthcare payer system and how we really are a collection of completely different states. And the way that COVID vaccine data is now being collected, and how a lot of the even case report forms are collected for all COVID test positive people, is by local health departments, boots on the ground, where that's then aggregated at the state level and then reported to CDC. And so there, is not yet one thoroughly curated, cleaned national vaccine data set with all of the personal information yet, but it's clear that we need it not only for research, but as we see other countries like Israel now implementing digital vaccine passports, that are able to show on your phone proof of vaccination status to be able to travel or to attend a large group event or a concert. I think that these things are of the momentum is gaining, that we need to improve our data infrastructure at a public health level to make sure that the opportunities for doing this well are able to be implemented.
Yeah, and actually following up on that, so we've obviously been using data in a very different way during this pandemic, and a lot of it, and people have come together in very different ways, and a lot of that is because there is something that's we're cohesively trying to fix. What are some of the ways that you think that you could see either it continuing post the pandemic? What are some uses of real world data that you think now have been kind of changed forever because of the pandemic that you would see benefiting other parts of either public health or the system? I mean, you were just talking a little bit about some of the infrastructure that might need to be developed as part of it, but are there other thoughts?
Well, I'm really excited and encouraged in CDC's efforts for data modernization. And even with the federal regulations now that are mandating interoperability of electronic medical record systems, it's a shame that when the pandemic hit, there was no ability to say, okay, we know there's all these people with COVID in the hospital right now. Like, what drugs are they all using? That's not a question that we could answer. There was not the ability for EHR because there are many different EHR companies across the United States and different ones in hospitals versus small clinics, we have not yet come up with a system where all of them can talk to each other, where we have the ability to rapidly learn, what drugs are people using, which treatments are the most effective for COVID. I think that to be able to do that in a representative way, we have to have interoperability and public-private partnerships. I think that in my experience working at a health tech company, it requires incredible investment and resources to build the infrastructure and technology for curation of complex unstructured data, like doctor's notes and lab results. And the government may not always have the incentives to build those technology platforms. And so I think this is where public-private partnerships have an opportunity, so that we have more of a safety net available when we need to call upon these resources that in peacetime, may not have a whole lot of use for the government.
And how do you see the use of real world data to help us determine when we reach herd immunity, or do you even think that's something that we'll be able to be informed by the real world data?
Ooh, herd immunity. I mean, both of us have worked in HIV modeling, so we care a lot about the spillover benefits to the community that we get as more and more people are protected. I think that herd immunity was a lot easier to talk about before there were variant virus strains that, our recovery from a natural infection or a vaccine will protect us against. So, it makes it a little bit more challenging to think through that. I think the way that we'll start understanding if we're achieving the benefits of herd immunity will probably be from the genomic surveillance of the positive COVID test results that we see within the United States. So it's also been revealed that all other high-income countries have huge, genomic sequencing capabilities and are, sequencing tons of viruses in their country. And then the US is like, oh, shoot, we forgot to build all that infrastructure, to sequence everything. But, as we build that and, start sampling, okay, like, of every 100,000 positives, let's sequence 5% of those and see, is it all wild type? Or are we getting a creeping increased amount of, variants we haven't seen before, or known variants of concern from these other regions? I think those will actually be some of the first clues if herd immunity is working. Maybe it's herd immunity against the wild type, but we'll have to change our policies if we see a creeping increase in some of these variants of concern.
And I guess, so one other question that's come up is that you've discussed kind of a need for a better system, a better infrastructure. And do you see that as something that is going to be able to be part of the solution with our current pandemic, or do you really see that as something for the next pandemic in terms of the needed resources and time to get something like that in place?
I think that there is opportunity to act now, and we're already starting to realize the benefits. When we think about even the types of COVID testing available, we talk about quick antigen tests or traditional PCR tests. But a ton of machines that have been sitting around unused during the pandemic are, these massive, huge sequencing machines, where at an individual person seeking a test level, it does not make sense it's like overkill to like fully sequence or put something into such a massive machine like that. But there are oftentimes opportunities where at a huge population level, all of a sudden efficiencies start to make sense. Where if you're going to do 100,000 people all at once, or pooled testing of schools where you swab all the kids in a classroom, put it in one tube, and then there's 50 classrooms at a school, you send 50 tubes, all the classrooms around send schools, you run it through a machine, and when you get hits, you're like, okay, close that classroom, that classroom, that classroom. and now I can see the sequence of that positive is reflecting the virus that's circulating in that community. So I think it's beginning, but that's why it's so important that we have the federal government coordinate this response together, because many of the opportunities don't make sense from an individual person's perspective or an individual business perspective, but together as a community, that's where we can get those efficiencies and advantages in ending things faster.
Okay, well, thank you so much. We've come to, I know we were trying to end about 12:45 and we've gone a couple minutes over, but there was a huge amount of information, and thank you everyone for the questions that were coming in through chat and through the Q&A. As mentioned before, the talk is going to be on the NHC website for people to be able to download and look at in the future, and then certainly reach out to myself or Dr. Adamson for any additional questions. And we'll look forward to the next seminar, which is going to be on March 12th. So thank you everybody for joining, and hope everyone has a good rest of the day and a good weekend.